Okay, the presentation now is about the choice of anticonvulsants for prevention and management of eclamptic seizures.
And it's not working?
No, it's working, yes. Just a few words about preeclampsia. I think the important thing that we need to do is, once preeclampsia is installed, we have to stop its progression. And anticonvulsants are a key component of it. The idea in this session, I will quickly and briefly review each of the alternatives that exist, and then I want to convince you that magnesium sulfate is really the best option. So magnesium sulfate was introduced first in the 20s, about 100 years ago. Probably it was used even before that. It's not a traditional anticonvulsant. The mechanism of action is still poorly understood. It may interact with some neuroreceptor transmitters and other mechanisms, but it plays a role in stabilizing the membranes in the brain and providing neuroprotection for the mother. There are some variation in the dosages and regimens of administration. There are some side effects. The most common is flushing, and everybody may have heard before about severe adverse events, and I want to de-emphasize those, or emphasize the fact that they are very, very rare, and the most common one is flushing, and so we shouldn't be worried too much about adverse effects of magnesium sulfate. The traditional alternative for magnesium sulfate has been diazepam, which is a benzodiazepine, and has been used since about 50 years ago. It's a traditional anticonvulsant and used for a wide range of other conditions. There are some side effects associated with that, like drowsiness, confusion, and amnesia. Phenytoin, it's another anticonvulsant that was about 30 years ago started to be used in the context of preeclampsia. It's used in epilepsy and other convulsion or other sources of convulsion. Also associated with some side effects like hypotension, cardiac arrhythmias, and other neurological problems. And this one that happily it's becoming less and less and less used, that's the lytic cocktail. It's a combination of 3 different drugs with various side effects, but fortunately it's no longer in widespread use. These recommendations, they are part of the WHO guidelines, and just to re-emphasize the fact that these recommendations, they are developed through a systematic process that has several steps that involves a systematic reviews of evidence, consultation among the international community, until they become published and official. The evidence base related to the use of anticonvulsants is summarized in this Cochrane systematic review for the prevention of eclampsia, where there are 15 randomized controlled trials, and we look at different comparisons. For instance, the use of magnesium sulfate versus a placebo or no anticonvulsants, magnesium sulfate versus phenytoin, diazepam, and others that have been tested as possible anticonvulsants. I don't want you to read the small numbers. I'm using here a color code. You have in the row, in the heading of the row in black, different outcomes, and the first one is the occurrence of eclampsia, right? Then we have different other conditions that are happening. But the color code that I want to emphasize is, whenever it's green, magnesium sulfate is superior than the comparison. So in the different comparisons, magnesium sulfate has been shown to be more effective in avoiding or preventing eclampsia. The yellow is when there is no actually difference, And for instance, the occurrence of some adverse effects when we use magnesium sulfate compared with placebo or other conditions, they are actually not very important. The only one that magnesium sulfate increases is the occurrence of any adverse effects that the main one is the occurrence of flushing in comparison with placebo. But that's an expected finding. So in this slide, what we are seeing is that in different comparisons, magnesium sulfate is a superior drug to prevent preeclampsia. When it comes to the treatment of eclampsia, there are different Cochrane reviews that look at different drugs and comparisons for treatment. This is when the women had already at least one conversion. And the same structure that we used before, the different comparisons and the different drugs and the different side effects. In this slide, again, it's not important that what I want to emphasize is the number of greens showing that the magnesium sulfate is a better drug than the other alternatives. When it's yellow, it means that there is no difference. But by the number of greens that we are seeing, that's showing the superiority of magnesium sulfate. These are maternal outcomes. So in several of the outcomes, magnesium sulfate is associated with a better outcome. And again, when we look at the fetal outcome, there are some conditions, for instance, the occurrence of low Apgar scores and other conditions. They are also improved with the use of magnesium sulfate. As you know, there are different regimens that are in use. There is, for instance, the Pritchard regimen, there's Zuspan, there are other variations. And they have been studied in some trials. And actually, there is not much difference between them. So if we look at different ways of administering magnesium sulfate, they tend to be similar. One question that we are interested in responding is whether giving only the loading dose would be enough, and for what kind of loading dose we are talking about. And so this is an area of still active research. But apparently, at least in terms of the maintenance alternatives, they are very much equivalent. How do we interpret this evidence? So the findings from research, they support the use of magnesium sulfate in severe preeclampsia to prevent progression to eclampsia. There is a clear evidence showing that magnesium sulfate treatment in eclampsia reduces the incidence of further fits. There is also clear evidence that magnesium sulfate is more effective than diazepam, phenytoin, and the Lytic cocktail in preventing further eclamptic fits. There is no clear evidence on which magnesium sulfate dosage regimen is better than the other, and most trials provide the evidence use the clinical monitoring in women undergoing treatment and non-uses serum monitoring. This, at some time ago, as you may know, there was a lot of concern about the adverse effects, and there was some groups advocating the use of serum monitoring or lab tests for assessing the therapeutic doses of the magnesium sulfate, and that's not needed. Only the clinical monitoring is enough. This evidence is summarized in the document that I was talking previously, which is available in this link. It's also available in its printed format, and there are guideline derivatives. There are summaries of evidence where this has been condensed in few pages, and they are also available in this link in several languages. They are available in English, Spanish, Russian, Chinese, Arabic, and the 6 WHO language or UN languages. And MCHIP is also working with us in producing a short derivative looking, targeting the field, and that will come out soon. The recommendations then are, this is coming directly from that document, saying that magnesium sulfate is recommended for the prevention of eclampsia in women with severe preeclampsia in preference to other anticonvulsants. Magnesium sulfate is recommended for the treatment of women with eclampsia in preference to other convulsants, so that's our drug. The full intravenous or intravenous magnesium sulfate regimens are recommended for the prevention and treatment of eclampsia. And as I mentioned previously, for settings where it's not possible to give the full magnesium sulfate regimen, the use of magnesium sulfate loading dose only, followed by immediate transfer to a higher level healthcare facility, is recommended for women with severe preeclampsia and eclampsia. In this slide, we just bring quickly the implications for clinical practice, and I want just to mention, someone in the previous session asked me about the dosage or the regimen that we are giving. I'm here just presenting the pre-chart one, that's the one that is given in the WHO, one of the WHO documents related to the management of complications during pregnancy and childbirth. That includes a loading dose of 4 grams of 20% magnesium sulfate solution over 5 minutes, associated with an IM dosage of 10 grams, 5 grams in each buttock. And as maintenance dose, we can use the 5 grams every 4 hours, or there is the IV continuous drug regimen. If there is, the woman has already received the magnesium sulfate and she has another fit, then we do a reload or with half of the dosage, with 2 grams of magnesium sulfate IV. Again, just to, and I will finish with this slide, and maybe if you can keep it a little bit so people can copy the link where they can obtain this document. The link is there. Document is available there. If you want, you can contact us to order printed copies for distribution. And there you as well, you find the summaries in different languages. Thank you.